Emergency drugs are those medications that are used in critical or life-threatening conditions such as cardiac arrest, septic shock, stroke, trauma, and epilepsy. Welcome to our channel. In this video, we will talk about some common emergency room medications that are used in life-threatening conditions. This list is not all-inclusive, so be on the lookout for part 2. The first drug is adenosine. Adenosine acts on alpha-1 receptor in the atrioventricular node, causing temporary heart block. It is effective in terminating stable supraventricular tachycardia and stable neurocomplex tachycardia. It is administered as a rapid IV push at a dose of 6 mg, followed with a rapid 20 ml normal saline flush. A dose of 12 mg may be repeated twice. The side effects include chest pain or tightness, flushing, and brief period of asystole or bradycardia. Adenosine is contraindicated in drug-induced tachycardia or second and third degree heart block. Adenosine is less effective in patients who are taking caffeine, theophylline, or aminophylline. Therefore, these patients may need higher doses of adenosine to see a response. The initial dose of adenosine should be reduced to 3 mg if administered through a central line. Also, lower doses should be considered in patients currently receiving carbamazepine, dipridamole, or in heart transplant patients. Remember, patients should be on continuous EKG, and the crash cart should be by the patient when administering adenosine. Next medication is amiodarone. Amiodarone is a class 3 antiarrhythmic agent that inhibits alpha and beta adrenergic stimulations. Also, amiodarone blocks sodium, potassium, and calcium channels. It prolongs action potential and refractory period in heart muscles and decreases atrioventricular conduction and sinus node function. In short, it helps keep your heart rhythm normal. It is effective for a variety of atrial and ventricular tachyarrhythmias such as pulseless ventricular fibrillation or ventricular tachycardia and wide complex tachyarrhythmias. The dose of amiodarone in pulseless VFib or VTAC is 300 mg IV push, followed by 150 mg IV rapid push if no response. The dose in stable wide complex tachycardia is 150 mg IV over 10 minutes, followed by infusion of 1 mg per minute for 6 hours, then 0.5 mg per minute thereafter. There is a maximum dose of 2.2 grams in 24 hours. The side effects include hypotension and bradycardia. With amiodarone, there are multiple complex drug interactions. Therefore, care must be taken when using this medication. Also, do not administer amiodarone with other drugs that prolong the QT interval, such as procainamide. Next, we have lidocaine. Although lidocaine is a local anesthetic, it also acts as a class 1 antiarrhythmic by blocking sodium channels. It is used in patients with ventricular tachycardia and ventricular fibrillation if amiodarone is not available or contraindicated. When used for VTAC or VFib, the initial dose is 1 to 1.5 mg per kilogram IV or IO bolus, and can repeat with a dose of 0.5 to 0.75 mg per kg every 5 to 10 minutes until symptoms subside or the maximum cumulative dose of 3 mg per kg or up to 300 mg has been reached. If IV or intraosseous access cannot be established, lidocaine can be administered through an endotracheal tube at a dose of 2 to 3.75 mg per kg and should be diluted before administration in 5 to 10 ml of normal saline or sterile water, with absorption being greater with sterile water than normal saline. After return of spontaneous circulation, lidocaine can be administered as an IV infusion at a rate of 1 to 4 mg per minute to prevent recurrent arrhythmias. The side effects include bradycardia and hypotension. Next, we have atropine. Atropine is an anticholinergic or antiparasympathetic and antimuscarinic that works by blocking the rest and digest part of the automatic nervous system. It is used in emergency conditions when your heart beats too slow. The dose in bradycardia is 0.5 to 1 mg every 3 to 5 minutes by rapid IV push with a 3 mg maximum cumulative dose. Atropine is also used in organophosphate or carbamate insecticide toxicity or nerve agent poisoning at a dose of 1 to 6 mg IV every 3 to 5 minutes as needed. And if the patient is requiring larger doses, atropine can be administered via continuous IV infusion. Also, atropine is used off-label in mushroom poisoning at a dose of 1 to 2 mg rapid IV push. Side effects include tachycardia and headache. Use caution in hypothermic patients since atropine can inhibit sweating and possibly lead to heat-related injury. Also, atropine should be used cautiously in patients with acute coronary ischemia or myocardial infarction because increased heart rate may worsen ischemia. Remember, atropine has no therapeutic benefit in pulseless electrical activity and asystole. Next, we have epinephrine, commonly known as adrenaline. Adrenaline is a chemical that narrows blood vessels and opens the airway in the lungs by stimulating alpha-1, beta-1, and beta-2 adrenergic receptors. Epinephrine is used in cardiac arrest at a dose of 1 mg IV or IO every 3 to 5 minutes. If IV or IO access is not available, epinephrine can be delivered via endotracheal route at a dose of 2 to 2.5 mg. Epinephrine is also a drug of choice in anaphylactic reaction at a dose of 0.3 or 0.01 mg per kg, intramuscular or subcutaneous, with intramuscular being the preferred route. It is also used to reverse airway obstruction in severe asthmatic patients. Epi can be used in symptomatic bradycardia and severe hypotension at a dose of 0.01 to 0.5 microgram per kilogram per minute and titrated based on clinical response. The side effects include hypertension and dysrhythmias. Use caution while administering epi as there are two available concentrations, 1 mg per ml and 1 mg per 10 ml. Therefore, be careful to avoid a 10-fold dosing error. 1 mg per 10 ml is used during resuscitation, and 1 mg per ml is used in anaphylaxis. Also, epinephrine can cause tissue necrosis, so it is recommended to administer through a central line, especially in IV infusions. Next, we have norepinephrine, commonly known as Levophed. Levophed belongs to a group of drugs called catecholamines. It has high affinity for alpha-1 receptors, providing a powerful vasoconstrictor effect, which in turn increases your blood pressure. It also has some effect on beta-1 receptors in your heart, which helps increase heart muscle contractions. Levophed is a drug of choice in cardiogenic shock when IV fluids are not effective, and it is administered as an IV infusion at a dose of 0.03 to 0.5 microgram per kilogram per minute. Side effects include tachydysrhythmia and tissue necrosis if catheter infiltrates or administered through an arterial line. Therefore, central line administration is preferred. Dopamine is another emergency medication that belongs to the catecholamine class. It works on alpha-1, beta-1, and dopaminergic receptors in a dose-dependent manner to increase cardiac output and systemic vascular resistance. At low doses, less than 5 microgram per kilogram per minute IV, it has dopaminergic effects causing renal vasodilation. At mid doses of 5 to 10 microgram per kilogram per minute, it has beta agonist effects, which causes heart stimulation, causing an increase in stroke volume, heart rate, and cardiac output. At higher doses of dopamine, 10 to 20 microgram per kilogram per minute, it has alpha receptor effects, which causes vasoconstriction and an increase in blood pressure. Dopamine side effects include tachydysrhythmia and tissue necrosis due to vasoconstriction. Next, we have dobutamine. Dobutamine is another emergency medication that belongs to the catecholamine class. It works mainly on beta-1 receptors, but also has some effect on beta-2 and alpha-1 receptors. Dobutamine is mainly used in acute congestive heart failure at a dose of 2 to 20 microgram per kilogram per minute IV infusion to increase cardiac output. Dobutamine side effects include tachycardia, hypotension if the patient is hypovolemic, and premature ventricular contractions. Next, we have esmolol. Esmolol is a selective beta-1 receptor antagonist that decreases heart rate and cardiac muscle contractions by blocking beta-1 receptors. Esmolol is an alternative option for treatment of AFib, A-flutter, and supraventricular tachycardia. It is also used off-label to control blood pressure and heart rate in patients with aortic dissection. The dose for Esmolol is 500 microgram per kilogram loading dose IV, followed by continuous IV infusion of 25 to 300 microgram per kilogram per minute. The side effects include hypotension and bradycardia. Esmolol can precipitate congestive heart failure, therefore avoid in patients with decompensated heart failure. Even though Esmolol is beta-1 selective, it should be used cautiously in patients with bronchospastic disease. Also, Esmolol is a vesicant and can cause tissue necrosis if extravasation occurs. Therefore, administration through small veins or butterfly catheter should be avoided. Next, we have nitroglycerin. Nitroglycerin is a nitrate, a potent vasodilator that relaxes vascular smooth muscles. It is effective in relieving pulmonary edema related to the left-sided heart failure. It is also used to relieve chest pain as a result of acute myocardial infarction. Nitroglycerin is administered under the tongue at a dose of 0.4 milligram. This dose can be repeated in 5-minute intervals to a maximum dose of 3 tablets in a 15-minute period. It is also administered via IV infusion at initial dose of 5 to 10 microgram per minute and may be increased by 10 microgram every 3 to 5 minutes until you've reached the desired effect, or to a maximum of 200 microgram per minute. The side effects include hypotension and methylglobemia, a rare blood condition which affects how red blood cells deliver oxygen to the cells and tissues. Nitroglycerin use should be avoided in patients with low systolic blood pressure, severe bradycardia, right-sided ventricular dysfunction, and patients taking phosphodiesterase 5 inhibitors, such as Viagra and Cialis. The next medication is mannitol. Mannitol is a highly effective osmotic diuretic that reduces pressure and swelling around the brain and the eyes. It is used in patients with elevated intracranial pressure due to cerebral edema, stroke, and head injury. It is also used to decrease intraocular pressure of the eye. Mannitol is administered at a dose of 0.5 to 2 grams per kilogram for 1 dose, infused over 30 to 60 minutes. And based on response and clinical status, a dose of 0.25 to 1 gram per kilogram can be given every 4 to 6 hours. The side effects include dehydration, electrolyte imbalance, and kidney dysfunction. Mannitol is contraindicated in patients with severe heart failure and severe kidney impairment with no urine output. Next is furosemide or Lasix. Lasix is a loop diuretic that acts on proximal, distal tubule, and loop of Henry to cause excretion of water, potassium, sodium, and chloride. It is used in patients with pulmonary edema or fluid retention in the body due to congestive heart failure, kidney disease, or liver disease. The recommended initial dose is 20 to 40 milligram IV push. The dose can be increased to desired effect with a maximum of 200 milligram for a single dose. Side effects include hypotension and ototoxicity. Since furosemide is a potent diuretic, it can lead to excessive water and electrolyte depletion. Therefore, close supervision is required and must be adjusted to the individual patient's need. Next, we have sodium bicarbonate, commonly known as sodium bicarb. Sodium bicarb is an alkalizing agent used in metabolic acidosis, which is a condition where the body produces too much acid. It is also used for hyperkalemia and tricyclic antidepressant agent toxicity, such as amitriptyline. The dose for metabolic acidosis and hyperkalemia is 50 milliequivalent IV times 1 dose. When used for tricyclic antidepressant toxicity, the dose is 1 to 2 milliequivalent per kilogram IV bolus. It is also used off-label for salicylate or aspirin toxicity at a dose of 150 milliequivalent in 1 liter of D5W given as a 10 to 20 ml per kilogram bolus, followed by a 2 to 3 ml per kilogram per hour, with a goal of urine pH of 7.5 to 8.5. The side effects include hypernatremia or high sodium levels and overshooting into metabolic alkalosis. Use caution in patients with congestive heart failure, edema, liver cirrhosis, and kidney impairment due to possible sodium retention. Next, we have magnesium sulfate. Magnesium sulfate acts on cardiac muscles by slowing down the rate of sinoatrial node impulse and prolonging conduction time. Magnesium sulfate is effective as an anticonvulsant and antiarrhythmic. It is recommended for use during cardiac arrest in cases of torsades or suspected hypomagnesemia at a dose of 2 grams diluted with 10 ml normal saline or D5W given slow IV or IO push. It is also used for seizure prevention and treatment in patients with eclampsia at a dose of 2 to 4 grams IV over 5 to 15 minutes. Mag sulfate can also be used in asthma exacerbation at a dose of 2 grams IV over 15 minutes. Also, magnesium can be used in digoxin toxicity, a medication used to treat heart conditions. The side effects include hypotension, respiratory depression. Also, in patients not in cardiac arrest, asystole may occur if administered too fast. Next, we have calcium gluconate or calcium chloride. Calcium chloride or calcium gluconate increases serum calcium and stabilizes cardiac muscles. Calcium chloride or gluconate is administered intravenously at a dose of 1 to 2 grams to stabilize cardiac muscles in patients with high potassium and dysrhythmias. The side effects include irregular heart rhythm, bradycardia, and phlebitis. Use caution when administering calcium chloride. It is 3 times more potent than calcium gluconate and can cause severe phlebitis with peripheral IV administration. Lastly, we have fosphenytoin. Fosphenytoin is an anti-seizure medication that stabilizes voltage-dependent neuronal sodium channels to stop seizure activity. The dose for status epilepticus is 15 to 20 milligram phenytoin equivalent per kilogram IV loading dose at a rate of 150 milligram per minute. An additional dose of 5 to 10 milligram per kilogram may be given 10 minutes after loading dose, with a maximum total loading dose of 30 milligram per kilogram. The side effects include drowsiness, dizziness, and itchiness. Be aware that rapid administration can cause hypotension and arrhythmias. Therefore, continuous cardiac and blood pressure monitoring is recommended. Thank you for watching and be on the lookout for part 2. Until next time, stay healthy and remember, health is the greatest wealth.